I'm really not going to talk a lot about pharmacology because, as you may already know, we don't have anything that really works and that has been designated by Health Canada that is specific to frontotemporal dementia. We're working on it. I'm hoping we'll get farther sooner, but what we really need to do is concentrate on what we can do at this point in time, right? We need to make sure that all the resources that we can garner for these families are in place, and that the families know what they can get from us. So I have a caregiver to a physician who developed one of these primary progressive aphasias. She's very articulate, and you'll see her a lot this morning as part of this presentation.
And I said, "Are you having the same problems at work that you're having with me?" And he said, "Nope, you're the problem, only with you." And of course, I believed it. I thought, oh, I'm an awful wife. I just need to be more patient. By the time we get to your office, we've been through hell. That's the only way you go to a neurologist's office. And we're already caregivers, and probably have been for quite a while, even if we don't know it. We're also terrified. We feel like informants against the mafia. It may be safe in your office, but then we're back out on the streets, and anything can happen. It's very unpredictable. So there's this constant internal debate about how much information we can give you. Can we tell the whole truth? I certainly didn't the first time around. I was terrified.
Quite a few issues. Oftentimes these patients are in a lot of denial about the fact that they have a problem. So we often have to separate the informant from the patient so that the informant can give us the whole story. The patient may be offended. The patient may just not understand what's happening and that that is abnormal, that that is an illness. Loss of insight is one of the criteria on the 1998 consensus criteria checklist that Karen flashed to you earlier this morning. I know that not all clinics have this luxury, but our clinic is set up so that the nurse can talk with the family in a separate room while I'm testing the patient. It's very important always, I think, to respect the needs of the different people involved. The patient really wants to be treated like the same full-grown, competent adult that he or she was up until this illness struck. And we need to help that person bring out his or her strengths and capitalize on those for a good quality of life. So the first question may be, how many patients do you have walking in the room on your first visit? And another thing that Katherine brought up was the consequences of delay in diagnosis. Oftentimes, people think that the person who's in their 50s or early 60s who's going through this illness is just having a midlife crisis. Or there's a confound from new substance abuse, alcoholism, or getting into some other kind of recreational drugs. They may be self-medicating to try to alleviate some of the symptoms that they're feeling. And that sort of error can lead to a long delay in making a diagnosis of a dementing illness. There are some spouse caregivers who have had it. There's new sexual promiscuity that was never there in the marriage before, and this person is out of control, not responsible with the finances. They figure, okay, this is it. I'm filing for divorce. Or they think, gee, the problem is me. I'm a bad wife, as Katherine is saying in the video. For some reason, I'm driving this person into unreasonable acts. So we need to do whatever we can to try to keep that diagnostic process as short as possible. Your roles, if you're working in day programs or in other service provision counseling for patients with dementia, may be to recognize this is not an Alzheimer's disease case. So we need to check further into what the accurate diagnosis may be, and then we can provide exactly the type of support that the caregiver needs. Financial risks. So there's a lot of stress for the household, because we usually have somebody who's still working at the time that they come down with the illness. We need to get in there with our case management or social work and try to make sure that they come away from that employment in a way that releases them of liability from decisions they may have made during the early stages of the illness while they were still working there, We also need to help them decide whether they want to apply for long-term disability versus taking early retirement. And depending on the person's job status and other conditions of employment, there's no one blanket rule for each patient. So here's another video clip. Katherine took her 2 children from a previous marriage on a vacation and came back to the husband at home.
Register the fact that pieces of furniture were missing and something was very amiss here. So I asked if we could discuss this in the garage, which is where we went. And in the next 45 minutes or an hour, I bounced between fear, sorrow, anger, pity, and piety. And I tried to make sense of what had happened, because basically what I discovered was that in the previous 7 days, he had made love to me and gone straight to the divorce attorney's office. He had registered a shotgun and pistol with the police that he had possessed illegally, and they were in the car that night, in the back of the car. And we had had an ongoing issue with this because I had discovered hollow point ammunition, a huge box of it, in a box of cashmere sweaters when he had promised me that he had no ammunition for these weapons. And he was supposed to be getting rid of the guns. He had hired an attorney to potentially sue his employer, which was completely deviated from his behavior in the past. This employer absolutely loved him and he loved them. It was a mutually respectful and beneficial relationship, but he became incredibly paranoid and decided that they were out to get him. He decided I was too. And he was sure that I was going to announce his illness to the media, when indeed I had managed the media because they were my colleagues and had protected him from everything he wanted to be protected from at the time. And he went and got wrote an affidavit out with the help of his attorney and got a verbal restraining order on me that he had intended to serve that night, that hour, with the divorce papers. I knew that our divorce would not have taken place if a brain illness had not been in the mix.
But the thing that really strikes me is her dedication. He's pushing her away. He's in denial about the fact that he's in trouble, that he has an illness. He's pushing everybody in his life away. This man had a very successful career in medicine and administration and teaching. But she's dedicated. She will wear herself out, if that's what it takes, to provide the best protection and the best care for him that she can. And that's something that we need to help the caregivers with. We need to give them a reality check. We need to help them pace themselves, because there's an urge to do as much as possible from the very get-go. But we know this takes a long time. We've seen it unfold over many years. The literature says 6 years. But almost all the patients that I started seeing in 1998 at UCLA only died within the last year. So we're talking a long haul here. It's not like cancer, where you got 6 months to live or 2 years on the outside. We need to help them pace themselves. We need to put the right resources in at the right time. Some of those resources are in terms of counseling and psychotherapy. Some of those resources are in terms of the medications that we can help to control behaviors as they ramp up. There's a whole phase of behaviors ramping up, and then there's that phase past the middle where the behaviors start to ramp down. And we need to be keeping track of whether we're over-drugging our patients. But everybody's in it for the long haul, and I think one of the things that works well for our team at Baycrest is that we tell them that congratulations, you're now part of a team, and we're going to get you through this.